Welcome to Deep Dive Ortho. Today, we're getting to grips with a really common yet, well, often quite frustrating wrist injury, the triquetral fracture.
That's right.
It might actually surprise you just how prevalent these are. We're talking the second most common carpal bone fracture,
Indeed. About 15 to 18% of all carpal fractures, give or take.
which is significant. But despite that, they're, let's face it, notoriously tricky to diagnose, often just labeled a wrist sprain.
Exactly. Or they're simply radiographically occult, just don't show up on the initial x-rays.
So our aim today is to really give you a deep understanding of these elusive injuries. We want to look at the subtle diagnostic clues, the surprisingly complex ways they happen.
Mechanisms, yes.
Yeah,
Which have evolved quite a bit.
and the latest thinking on management, both conservative and surgical. We've got our expert here to guide us through all this.
Thank you. It's great to be here. We're talking about a small bone, the trichomum, but one that plays a really pivotal role in how the wrist works.
Can you just remind us where it sits anatomically?
Of course. So if you picture the wrist, the triquetrum is this sort of wedge-shaped bone. It's in the proximal carpal row, over on the ulnar side, the little finger side.
Okay.
And its position is key, connects with several neighbors, the lunate bone next to it, the pisiform sits right on top, volarly, and the hamate is distal to it.
Right. And its connection to the ulna.
Ah, well, that's interesting. It doesn't directly touch the ulna. Instead, it connects via the TFCC, the triangular fibrocartilage complex.
Disc.
Precisely. Which acts as a crucial shock absorber and stabilizer for that medial side of the wrist. And another really important point, its dorsomedial surface, the back, has these two significant areas where ligaments attach, strong ligaments.
Ah, okay. So not just bone-on-bone articulation, but critical ligament anchor points, too.
Exactly, and that's why when the triquetrum gets injured, it's really just the bone itself. The surrounding structures, especially those ligaments, are often involved. It sort of sets the scene for why these injuries can be complex.
That's a perfect setup. It immediately tells us we're not just dealing with a simple chip. So let's dive into that complexity. How do these fractures actually happen? There's been quite a debate over the years, hasn't there?
Oh, absolutely. A real sort of historical back and forth. It mainly centered around two competing ideas, ligament avulsion versus impaction.
Pull versus push, essentially.
You could put it like that, yes.
Yeah.
The traditional views were fairly distinct. First, you had the ligament avulsion theory.
Right.
This suggested that these fractures, particularly the common dorsal ones, happened when a ligament attaching to the triquetrum was pulled so hard. Perhaps during a fall, with the wrist bent sharply forward and inwards, palmar flexion and radial deviation, that the ligament just pulled a fragment of bone off with it. Simple tensile failure at the insertion site.
Okay, so a pulling mechanism. What was the alternative?
The alternative was the endocarpal impaction theory. Garcia Elias, a well-known hand surgeon, really detailed this. He proposed a chisel action. Yes. The idea was that the ulnar styloid process, that bony bump on the end of your ulna, acted like a chisel. During forceful dorsiflexion, bending the wrist back hard, combined with ulnar deviation towards the little finger.
That classic fall mechanism.
Exactly. The styloid would supposedly strike the dorsal aspect of the triquetrum and chip a piece off. And this theory gained some traction because some studies noted a slightly longer ulnar styloid in these patients. They measured the ulnar styloid process index, the USPI.
Right, I remember reading about that. I mean, USPI of about 0.29 was reported?
That's the figure often cited, suggesting a longer styloid might predispose to this impaction. Then later, Hucker and Menschik sort of expanded on this impaction idea.
How so?
They suggested it wasn't maybe just the ulnar styloid. They argued that the edge of the hamate bone, the dorsproximal edge, could also act as a chisel against the triquetrum in that same extended ulnar deviated position.
Okay, so a similar impact mechanism, but potentially from a different bony structure. So historically, it was pull versus impact, either from the ulna or the hamate.
That was the basic picture, yes.
But as often happens in medicine, things aren't usually that simple, are they? What have newer techniques, especially MRI, shown us? Has it clarified things, or dare I say, made it even muddier?
Well, complex might be a better word than muddy. But yes, you're absolutely right. Modern MRI studies, like the one by Bess and colleagues, have really peeled back the layers here.
Okay.
And their findings don't just tweak the old theories. They challenge some of the fundamental assumptions and show it's often a much more mixed, multifactorial picture.
How so? Let's take the ulnar styloid impaction theory first. What did the MRI data show there?
Well, firstly, the average USPI they found in their patients was 0.21.
which is normal.
Exactly,
Yeah.
within the normal range.
Yeah.
Not consistently high like the theory predicted. But here's the really interesting bit. The median USPI was actually higher in patients whose injury story sounded more like an avulsion 0.27.
Higher in the avulsion group.
Yes, compared to those whose story suggested impaction, where it was 0.20. So that directly contradicts the simple idea that a long styloid equals impaction fracture. It's clearly not that straightforward.
Okay, that's definitely counterintuitive. What else did the MRI reveal about the ulnar styloid's role?
This is perhaps the most damning evidence against the direct ulnar styloid chisel idea, at least in the cases they studied. They found no fracture or even bone marrow edema, bone bruising in the ulnar styloid process itself in any of their patients with triquetral fractures.
None at all.
None. And you'd really expect to see some sign of trauma on the styloid if it was directly hitting the triquetrum hard enough to break it.
That seems pretty conclusive for those cases, doesn't it? It makes direct impaction from the ulna seem unlikely as the sole cause.
It certainly makes it much less likely in those instances, yes. However, the hemi-impaction theory did get some support.
Oh, okay. How?
They did find bone marrow edema in the Hanat bone in nearly a quarter of the patients, 23.8%, which does suggest that the hemo hitting the triquetrum, as Hucker and Menchik proposed, could well be a contributing factor in that extended ulnar deviated position. So maybe the heme is the more common impactor than the ulna.
Okay, so the picture is shifting. Less ulna, maybe more heme involvement in impaction. What else complicated the simple avulsion versus impaction story?
Well, they looked at specific fracture patterns using the Garcia-Elias classification we'll discuss later. He'd suggested type 3 fractures partially displaced at the distal end were likely avulsions. And Bess's group did find a lower mean USPI for these, 0.17, which sort of fits. But crucially, they found this type 3 pattern was significantly more common in the group whose history suggested impaction.
Oh, right. So the pattern associated with a lower USPI thought to be avulsion was actually more common in the impaction group.
Precisely.
Yeah.
It just doesn't fit neatly into either box. It suggests a real overlap, maybe a combination of forces, rather than one single mechanism defining the fracture type.
Okay, it sounds truly multifactorial. And what about the ligaments in all this? Did they find differences between the avulsion and impaction groups there?
This is probably the most critical finding, clinically speaking. They found no significant difference in how often associated ligaments were torn between the supposed avulsion and impaction groups.
Really? So regardless of whether it looked more like a pull or a push fracture?
The surrounding ligaments were just as likely to be injured. It strongly points towards a complex, combined injury mechanism where the soft tissues nearly always take a hit, whatever the primary force on the bone appears to be.
Wow. So the key takeaway is, forget simple either. It's a complex interplay, and assume ligaments are involved.
That sums it up perfectly. It's a dynamic event affecting the whole complex.
So if the mechanism is this complex, does that translate into different types of triquetral fractures? And, more importantly, given what we've just heard about ligaments, what associated injuries should we really be looking for?
Absolutely.
Yeah.
Understanding the different fracture types is key for management. For the common dorsal cortical fractures, the Garcia-Elias system is useful. It goes from type 1, undisplaced.
Just a crack.
Essentially, yes.
Yeah.
Types 2 and 3 are partially displaced, either proximally or distally. Type 4 is completely displaced.
Okay.
Type 5 means multiple fragments, more comminuted. And type 6 is a more significant verticofrontal fracture involving the whole dorsal surface.
Right. But beyond those dorsal ones, what are the main anatomical types?
Broadly, we think of three main types. First, the dorsal cortical fractures we've been discussing. They make up the vast majority, 93 to 95%.
And often called benign.
Historically, yes, but maybe that's misleading given the ligament issue. They typically happen from falls onto an extended ulnar deviated wrist, the impaction scenario, but they can also result from avulsion of the dorsal radiotriquetral or scaphotriquetral ligaments, particularly in wrist flexion with radial deviation. So, same fracture appearance, potentially different initiating force.
Understood. What's the second type?
Second are triquetral body fractures. These are less common, but generally indicate higher energy trauma.
More serious, then.
Definitely. Because they involve the main structural part of the bone. You often see these alongside really significant wrist injuries, like paralunate fracture dislocations.
Ah, right. Part of a bigger picture.
Exactly. A triquetral body fracture is found in something like 12 to 25% of paralunate injuries. It's a red flag for major carpal disruption. The mechanism is usually direct compression, axial loading, or crush injuries.
Okay.
And because they're central and high energy, they're often associated with a whole host of other problems. lunar triquetral ligament tears, scaphoid fractures, distal radius fractures. You have to look carefully for these associated injuries. Missing them is bad news.
Absolutely. And the third type?
The least common, but potentially the most problematic for stability, are volar cortical fractures.
On the palm side.
Yes, usually caused by avulsion of the volar ligaments, like the ulnotriquetral or lunotriquetral ligament.
Why are they more problematic?
Because those volar ligaments are absolutely critical for maintaining the alignments of the carpal bones. Injuring them carries a much higher risk of leading to carpal instability, which can cause long-term pain and dysfunction if it's not picked up and managed correctly. They need a high index of suspicion.
So it really hammers home that point about associated injuries. It's not just the bone. And that BEST study you mentioned really quantified this ligament issue, didn't it?
It really did. And the figures are, well, quite sobering. They found that an incredible 95.2% of patients with dorsal triquetral fractures had at least one associated dorsal carpal ligament injury.
95%.
20 out of 21 patients. It essentially means if you diagnose a dorsal triquetral fracture, you should assume there's significant ligament damage until proven otherwise.
That completely changes the perspective from a simple fracture or sprain.
It absolutely should. The specific breakdown was also revealing. Dorsal ulnotriquetral ligament tears were seen in 81%, dorsal intercarpal ligament tears in 76%, and dorsal radiocarpal ligament tears in about 67%. These ligaments are almost routinely injured alongside the bone.
Is there any correlation between where the bone bruising is on MRI and which ligament is torn?
Interestingly, no. They looked for that, but found no statistically significant link. Where the bone marrow edema was located didn't reliably predict which specific ligament was injured.
So you can't rely on the bone edema pattern to guide you on the ligaments?
Not reliably, no. The implication is clear. High suspicion of ligament injury is warranted in nearly all cases, irrespective of the precise edema pattern on the MRI.
Okay, that 95% figure is the one I'll take away. Assume ligament injury. Now, if we need to assess these ligaments, especially with MRI, how well can we actually see them? Are there imaging pitfalls we need to be aware of?
That's a very practical question. Generally, 3D gadolinium-enhanced MRI using sequences like VBE is pretty good. The BEST study identified over 92% of these ligaments in healthy controls.
So MRI is the tool.
It's definitely our best tool for soft tissues, yes. But, and it's an important, but visibility isn't perfect for all the ligaments.
Which ones are tricky?
Well, the dorsal intercarpal ligament showed up very well, completely visible in almost 97% of cases. The dorsal radiocarpal was also good, 80% complete visibility.
Okay.
But the dorsal ulnotriquetral ligament was much more challenging. It was only completely visible in about 53% of cases. And worryingly, it wasn't seen at all in nearly a quarter, 23.3% of the healthy controls.
Not seen at all, even when presumably intact.
Exactly. So if you don't see it clearly on the scan, you can't automatically assume it's torn or absent. There might be technical limitations.
Why is that one harder to see?
It's likely due, at least in part, to something called the magic angle artifact.
Right, I've heard of that.
Because ligaments are ordered collagen fibers, if they lie at roughly 55 degrees to the main magnetic field of the MRI scanner, they can produce an artificially high signal.
Making it look like a tear.
Precisely. Or just making it blurry. The dorsal ulnotriquetral ligament has a curved path, and combined with the short echo time, TE, used in some sequences, it's particularly susceptible. So you have to interpret findings relating to that specific ligament with a degree of caution. Reported tear rates might be slightly inflated due to this artifact.
That's a really crucial point for interpreting MRI reports. Combine the imaging with the clinical picture and be aware of potential artifacts.
Absolutely. Clinical correlation is paramount. Know the limitations of the test.
Which leads us perfectly into evaluation and diagnosis. Given these challenges, occult fractures, tricky ligaments, what should alert us clinically? What's the typical presentation?
Well, the starting point is always that high index of suspicion, especially with the right history. Clinically, patients usually complain of quite specific ulnar-sided wrist pain. Often, yes. They might say it's worth with bending the wrist, flexion, or extension. You often find some swelling on the dorsal side, and the key sign is usually localized tenderness right over the dorsal aspect of the triquetrum. If you press there, they'll likely jump.
Okay. And the history?
Typically, it involves excessive load or the classic fall onto an outstretched hand for injury, often with the wrist extended and pushed towards the little finger side, that ulnar deviation.
Right.
Think of someone falling backwards. But remember, the flexion radial deviation mechanism can also occur, so keep an open mind. Some also say wrist flexion can be more painful if it displaces a dorsal fragment.
Good tip. Now, the radiographic challenges. You mentioned occult fractures. How often are we talking?
It's surprisingly often. Some older studies suggested up to 80% might be missed on initial plain X-rays.
80%. That's huge.
It is. Even the best MRI study found 19% were occult on the initial radiographs they reviewed. It just highlights how insensitive standard X-rays can be for these small, complexly located bones. Compared to, say, a scaphoid fracture, the combined sensitivity of clinical exam and X-ray is often lower for the triquetrum.
So what X-ray views should we be ordering to maximize our chances?
You definitely need more than just the standard PA and lateral, although the lateral is often the most useful for seeing dorsal fragments displaced posteriorly.
Okay.
You should also get a 45-degree pronated oblique view. This can sometimes rotate the triquetrum out from overlapping bones, and a radial deviation view might help highlight volar fractures by tensioning those ligaments.
Any specific signs to look for?
There's the slightly amusingly named pooping duck sign.
The what now?
The pooping duck. On the lateral view, sometimes the trigger profile looks a bit like a duck's head, and a dorsal cortical fragment can look like it's, well, exiting posteriorly. It's quite memorable if you see it.
I'll definitely remember that one. But even with these views, many are still missed.
Yes, a significant number. So the rule has to be, if you strongly suspect a triquetral fracture based on the clinical picture, but the X-rays are normal or equivocal, you must pursue further imaging.
Which brings us to CT and MRI. If X-rays aren't enough, what's the specific role for each of these? When do you choose one over the other?
Excellent question. They both have critical but slightly different roles. CT is brilliant for bone detail. It's really the next step if you suspect an occult fracture that X-ray missed.
Better at seeing the fracture line.
Much better. The cross-sectional views cut through the overlap issues. CT is also more accurate for measuring the exact size and volume of any fragments, which can be really important if you're considering surgery, deciding if a piece is big enough to fix, for example.
So high clinical suspicion, negative X-ray CT for bone.
That's a very common and logical pathway, yes. But MRI comes into its own, crucially when you're worried about instability or, as we've discussed extensively, associated ligament injury.
Which is almost always.
Which is in over 95% of cases, according to that BEST study. So MRI is often essential. It's also useful if CT is negative, but you still suspect an occult fracture, as MRI can pick up bone marrow edema, the bruising, even before a clear fracture line forms.
And it shows the soft tissues.
Exactly. Ligaments, the TFCC, cartilage. Given the high rate of ligament tears, you could argue MRI is needed in most cases to get the full picture and plan treatment properly to avoid long-term problems like instability.
So it's not really an either with CT and MRI sometimes.
Often not. You might need both depending on the clinical question. CT for the bone detail, MRI for the soft tissues and subtle bone injury. And don't forget to look at the other carpal bones too. BEST found edema in the hamate in nearly 24% of cases, and in other wrist bones in 19%. It's often a wider injury pattern.
Right, a comprehensive assessment is key. Okay, let's say we've navigated the diagnosis, we got the imaging, we know the fracture type and any associated injuries. How do we manage these? What's the first-line approach usually?
For the majority, especially those undisplaced or minimally displaced dorsal cortical fractures without instability, non-displaced body fractures, and stable volar fractures, non-operative management is definitely the way to go.
Good news for the patient.
Absolutely. The triquetrum generally heals well thanks to a decent blood supply. The mainstay is immobilization, usually for about 4 to 6 weeks.
How is that typically done? Just a cast?
It's usually phased.
Yeah.
Initially, say for the first few weeks while things are swollen and sore, a volar splint is often preferred. Wrist in slight extension.
Oh, movable.
Yes, which allows for gentle range of motion exercises, just wiggling fingers and thumb, and for hygiene. Cold packs are also really helpful in this early phase, especially the first 72 hours, to manage that swelling and pain.
Okay, splint first, then what?
Once the initial swelling settles, maybe around the 2-4 week mark, depending on the case, you might transition to a proper short arm cast for more rigid support as healing progresses.
And after the cast comes off?
Usually around 4 weeks, maybe slightly longer, you'd move to a removable wrist splint or brace. This allows for gradual increases in movement and starting gentle strengthening exercises. The goal is regaining mobility without stressing the healing site too much.
When can patients expect to get back to normal activities?
Weight-bearing activities can usually be gradually resumed around 8 weeks post-injury, assuming things are progressing well and pain allows. Full, unrestricted activity might take a bit longer.
And the outcomes with this conservative approach?
Generally very good. Most fractures managed this way heal well, often with what's called a fibrous union.
Not solid bone.
Not always solid bone, but strong fibrous tissue connecting the fragments. And crucially, this is usually completely asymptomatic. Patients typically get significant pain relief and recover good wrist motion, often within 6 to 8 weeks of starting treatment. So for most, surgery isn't needed.
That's very reassuring. But inevitably, some cases do require surgery. What are the main indications for going down the operative route?
Yes, surgery definitely has its place. The main triggers are significant displacement of the fracture fragments, clear evidence of carpal instability, associated fracture dislocations involving the triquetrum, or those relatively rare cases of symptomatic non-union where conservative treatment has failed and the patient still has pain or mechanical issues.
So instability and significant displacement are key flags.
Absolutely. The goal of surgery is to put things back where they belong, make the wrist stable, and optimize long-term function.
What surgical techniques are typically used?
It depends on the specifics, of course. Open reduction internal fixation, or ORIC, is common for displaced body fractures or instability.
So opening it up and fixing it.
Exactly. You make an incision, carefully reduce the fragments back into place, and then fix them internally. You might use small interfragmentary screws to compress the fragments, or perhaps K-wires, which are temporary pins. If ligaments need repairing, you might use suture anchors drilled into the bone.
Right, like Herbert screws for fracture dislocations.
Herbert screws were often used, yes, sometimes combined with K-wire stabilization across the lunotriquetral joint if needed.
Okay, so RIF is one option. Are there others?
Yes, particularly for those problematic symptomatic non-unions, especially if it's a small fragment and not involving the joint surface.
Not articular.
Precisely. In those cases, fragment excision, just removing the troublesome little piece, can be a very effective option.
Just take it out.
Yes. Sometimes trying to fix a tiny chip is more trouble than it's worth. There was a case report of a young man with a tiny, painful non-union, only about 5 millimeter. They excised it, brief immobilization, and he became pain-free. Others have reported success excising slightly larger fragments too. It's a good option for selected cases.
That makes sense for small, non-articular, persistently painful fragments. What about post-op?
Still needs immobilization, of course.
Mm.
Maybe 6 weeks in a cast, then a brace, followed by rehab. Outcomes are generally good, maybe some slight loss of flexion or extension compared to the other side, but usually satisfactory function and pain relief.
And crucially, you have to address the associated injuries found earlier.
Absolutely vital. If the pisiform is subluxed, you might need to excise it or fix the triquetrum. If the lunotriquetral ligament is unstable, it needs pinning or repair. Surgery has to address the whole problem, not just the triquetral fragment in isolation.
It really highlights that holistic diagnostic approach again. Okay, so after treatment, whether conservative or surgical, what's the general outlook and what potential complications should we be keeping an eye out for long term?
The overall outlook is generally positive. As we said, functional recovery is typically good to excellent for most patients, even those with some associated ligament issues, provided they're managed correctly. People often get back to good function relatively quickly.
That's good to hear. What about non-union? You mentioned it's rare but can be symptomatic.
Yes, true non-union is uncommon, especially in body fractures. Fibrous union is more frequent and usually fine. But if a true non-union does occur and becomes symptomatic, causing persistent pain or clicking, that's when it can cause significant disability and might need that surgical excision or fixation we discussed.
Okay. What other long-term issues can crop up?
Well, related to the associated injuries mostly. TFCC injury is common, especially with dorsal fractures. If it remains symptomatic despite initial treatment, it might need arthroscopic debridement or repair later on.
Right.
Pisiform arthrosis arthritis in the joint between the pisiform and triquetrum can develop if the fracture went into that joint or sometimes related to a non-union there. If that becomes painful, excising the pisiform can be a good solution.
Makes sense.
And the big one, though thankfully less common if things are managed well initially, is persistent carpal instability. This usually results from missed or undertreated ligament injuries, especially involving the lunotriquetral ligament. It really underlines why that initial, thorough assessment with advanced imaging is so incredibly important to catch these instability patterns early.
Absolutely. Preventing that long-term instability seems key. Well, this has been an incredibly thorough exploration. We've really covered the ground from presentation to long-term follow-up.
We have. It's clear that these fractures, despite being common, are anything but simple. From understanding the shift in thinking about mechanisms away from simple, either to this complex, multifactorial picture revealed by MRI,
Hmm.
to appreciating that staggering 95% rate of associated ligament injuries, it really changes the game.
It really does. It mandates that high index of suspicion and the readiness to use advanced imaging like CT and MRI, not just for the bone, but critically for those soft tissues. It's about seeing the whole wrist complex.
Precisely. And then tailoring the management, knowing that most do well with straightforward immobilization, but also recognizing the clear indications for surgery, like ORIF, or even fragment excision when needed.
This deep dive has certainly illuminated a corner of wrist trauma that deserves careful attention. It might look like a small chip, but the implications can be significant.
Indeed.
If you, listening, found this deep dive valuable, please do consider leaving us a rating or perhaps sharing it with a colleague. And finally, a thought to take away and perhaps ponder. Given everything we've discussed about the extensive soft tissue attachments and that near-universal ligament involvement, how might future advances perhaps in dynamic imaging techniques or maybe even intraoperative assessment tools further refine our understanding of wrist kinematics after these triquetral fractures? How could that ultimately help us improve long-term stability and function for our patients even more?